Thank you, Dr. Abdurrahman, for making my speech easier. So I'm going to touch on the same subject that Dr. Numeri spoke about. I'm going to share with you our experience in Tawam Hospital in managing this problem, which is a bit different from the previous speaker. We know that leak is the most serious and dreadful complication that everybody thinks of before sleeve gastrectomy. Even patients nowadays, they come and they ask you about the percentage of leak, what if I had a leak, what will happen. So what we did actually in Tawam Hospital, we analyzed the cases that we treat for leak, and I'm going to share with you our experience. So the methods for this study, we did a retrospective analysis for the cases that was dealt with in Tawam Hospital between January 2009 and January 2014. We review our treatment plan, we review the management plan and the outcome of the patients. We had a plan in Tawam Hospital whenever we have a suspected leak. So our algorithm will start with, first of all, controlling the sepsis, the minimally invasive way if possible. So if we had a single collection next to the sleeve, we proceed to an image-guided drainage, CT or ultrasound-guided. If we have multiple abscesses, obviously this will not work, so we have to go to the operating theater and do a laparoscopic drainage. The next step in the management after controlling the sepsis is doing an endoscopy with stenting. Of course, we need to feed these patients, so our options are either TPN or nasojejunal tube, or if the stent was successful, they will consume oral diet afterwards. Of course, with antibiotics, PPIs, and other treatment modalities. So the analysis of our patients between January 2009 and 2014, we treated 26 cases of leaks. Now, 7 of these cases we exclude from this study because there were leaks after gastric bypass. So we ended up with 19 patients with leak post-sleeve gastrectomy. From those 19s, we have both from our center and referred from an outside facilities. As for the patient demographics, the median age was 34 years. The male-female ratio was like two-thirds of these were males. The mean BMI was 44, ranging from 32 to 59. And according to the center, we have 8 leaks in Tawam Hospital, and 11 was referred from an outside facility. So sorry for that, it was better than this before. Just to give you a clue about the procedures that has led to the leak, in 13 of these patients, it was a primary sleeve gastrectomy. In 3 of those patients, the procedure was a single incision, laparoscopic sleeve gastrectomy. 1 of them is a sleeve gastrectomy post-VBG. 1 of them post-removal of band and sleeve gastrectomy in a single stage, and 1 of them was removal of band and sleeve gastrectomy in 2 stages. So, and actually the cells, the VBG and the removal of band and sleeves, those are our cases. So basically, we have like 6 out of the 8 leaks were revisions in TAWA. How do these patients present usually? I mean, the main presentation was abdominal pain and fever. We have rare, unusual presentation. One of the patients presented with a massive upper GI bleeding. The other patient presented only with an acute renal failure without any other complaints. 1 patient presented with left subphrenic collection, and 1 of the chronic leaks presented with a gastropronchial fistula that was actually referred from another facility. So when we analyze this data, what we found is that the leak was diagnosed ranging between the day 2 and the day 21 post-surgery in 17 out of the 19 patients we had. 2 patients presented chronically, 1 of them with a gastropronchial fistula. The leak location was in the GE junction in 95% of the cases. Only 1 patient presented with a leak in a distal stable line next to between the first and the second stable firing. We implement EGD and stenting in all those patients, in 100% of these patients. And CT guided drainage was done in 17 of these patients. Two of those patients we had to go to OR due to multiple abscesses and due to the state of the patient where they were unstable. Again, laparoscopic drainage, as we mentioned, was done in 10% of the cases. The average time for stent removal, as mentioned by Dr. Numeri previously, it's not very clear, but usually in our group it was 4 to 6 weeks post-implantation. The mean hospital stay ranges between 10 and 55 days with a mean of 29 days. The mean follow-up of this group of patients was 15 months, ranging from 5 to 38 months. So, as also mentioned by the previous speaker, the stent doesn't come free of charge. Everything has its own problems. What we encounter in this group of patients is that the most common complication or the most common complaint after stent implantation was retrosternal pain, which is usually severe. And we had 2 or 3 patients who does not tolerate the stent, and we have to remove it 2 or 3 days after implantation. And the salivation, for some reason, with the esophageal stents, they continue to just produce saliva. Nausea, vomiting is one of the common problems as well. We have 2 cases where the stent was migrated, as you can see in the picture. The complete stent went down, and in one case the stent was kinked and actually was causing obstruction that we have to remove and to replace with another stent. So, from this group of patients, our results was promising. We had a complete healing with this method in almost 90% of the cases. Actually, those are the acute leaks, the ones that was diagnosed in the first 2-3 weeks. The 2 chronic leaks, however, they failed to close with stent, and we have to convert these to another procedures. So, I mean, I'll give you a hint about some literature regarding the stents in treatment of leaks. And most of this literature, actually, I found in the thoracic surgery literature about esophageal perforations. But we'll start with this bariatric paper from Jack Himbens, which was published in 2009. And he's talking about 29 patients who were treated for leak post-sleeve gastrectomy. And what they found is that it's a feasible thing. He didn't mention the success rate, but however, he said that it's something that can be used in treatment of leaks post-sleeve gastrectomy, and it's a better option rather than converting these patients to Roux-en-Y gastric bypass. Another paper that's from the thoracic surgery, and this paper actually talks about, sorry for that, talks about leaks after esophageal perforation. And also, again, they talk about 157 patients who was treated successfully with using self-expandable metallic stents together with the drainage of the abscess, whether it's in the chest or in the abdomen, and with a success rate. Another paper in 2010 also talks about using of metallic stents. 25 patients included, and it shows the same results. Another paper, this is recent, was published in June 2014, talking about leaks specifically post-sleeve gastrectomy. And again, they talk about the use of stents is feasible and is better than going for conversion to esophagogenostomy or a Roux-en-Y gastric bypass with a high success rate. And this last paper actually was published 2 months ago in December 2014, and it's from Dr. Sabah in Kuwait, our dear colleague. And he presented 17 leaks with a success rate of 76% with the same management plan, which is control of sepsis, drainage of abscesses, and use of plastic stents or metallic stents for the treatment of this problem. Again, another paper talks about metal stenting, and it shows also the same results. Another one from 2014 from the States shows the same also. So to conclude, Mr. Chairman, ladies and gentlemen, non-operative management or minimally invasive, let's call it, percutaneous drainage with use of stent is something feasible, safe, and effective in treatment of stable line leaks. In our hands, I mean, the success rate was almost 90%. However, there are issues with this. I mean, there are long hospital stay to consider. There are the costs of the treatments to consider. There are the stent complications also to consider. But again, this is a much better option, we think, better than converting those patients to root gastric bypass or mini gastric bypass or esophagogenostomy. This problem always requires multidisciplinary approach, and here I would like to acknowledge all the team members who was involved in this study, namely our gastroenterologist, Dr. Taha, who was a great help in this, the ICU physicians, our intervention radiologists, our nutritionists, our psychiatrist, which plays a major role in controlling those patients after stents and with this long bad trip in the hospital. And one last point I would like to emphasize, as Dr. Numeri also mentioned, that is prevention of this dreadful complication is the most important option. Prevention includes good surgical technique, bougie size, reinforcement, whether with suturing or with buttressing material, although we don't use that at all, but I mean, this is something to think about. And more importantly, the early detection of this problem and dealing with it seriously is the key for the treatment, because many times we plan something and we have a problem which was unexpected. So with this, I can conclude. Thank you very much for your attention.
We are open for questions. Any question? Yeah, please.
I just would like to know what type of stent have you used in your experience? What did you use?
Well, basically, we start by using the plastic stents, the short ones, the 12-centimeter ones. But whenever we see a stenosis on the gastrographene swallow or in the endoscopy that there is a stenosis or kinking, we started using the longer ones, which covers the whole sleeve. It's very important not only to cover the leak side, it's also important, as mentioned by the previous speaker, if there is a distal stenosis that should be dealt with. Otherwise, your leak will never heal. So recently, I would say in the last 10 or 12 patients, we were deploying the plastic stents, the long ones, the 18 centimeters one.
Do you feel it's a good idea to try to pass the pylorus as well with your stent? Because I think it is probably important. With the long one now, you can go from distal esophagus to post-pyloric.
How long would that stent be?
There is a Korean stent which is on the market, which is expandable and removable. Yeah. Because I have not a big experience of leak and stenting, but the one I have in the early days, we have to double. Sometimes you can even double stent.
You can double stent.
And it actually holds the stent better.
You're right.
You can even triple stent.
Actually, few of these cases were double stented because of the persistent leak from around the stent. So you go again, you repeat. What we do for those patients is that we do a control every week, a gastrographene swallow, to see the stent place, if it migrates, if there is any persistent leak. And in few of these cases, I remember we have to double stent. Sometimes we have to remove the stent, replace it with the other one. However, by passing the pylorus, I have no experience with that. We've never done that.
Huh?
I think 22 to 24 centimeters are available outside, but
we don't have them.
In UAE, maximum is 18 centimeter available.
Yeah, the longest is 18.
Well, we had a limited experience with stents bypassing the pylorus. We used them 3 times, and 2 of them migrated. So we stopped doing that, and now we're going to the pylorus and clipping the stent at the pylorus there. But it's not beyond. just before it, but we clipped. Our experience with this limited number was not that good, really.
And something else I just forgot to tell you that I've done once for one of my friends in Sydney, which had more experience with leak, unfortunately, is you can laparoscopically, when you do a laparoscopic washout, if you do stand the patient on the table, you can actually, because of the migration issue, you can suture the stent laparoscopically to the stomach wall through the stomach.
Yeah.
And
what
with an absorbable suture. At least he doesn't know, I know what I mean, but it's not a bad idea.
But in this case, you have to take the patient to OR. I mean, you can't do that when you are in the operating theater. The cases I'm talking about is mostly were done in the radiology, CT-guided drainage, and then taken to the endoscopy suite. However, our gastroenterologist sometimes advocates that he can clip those staplers to prevent them from migration, but we've never had this before.
There is one series published in using long stents past the pylorus. The biggest issue is bile reflux gastritis. The patients have problem of bile reflux. Like when you
No, we have no experience with that. We've never used them before.